In the next two videos, we will talk about the importance of health equity in the COVID-19 vaccination process. This video will focus specifically on racial and ethnic minorities and immigrants and refugees, while the next video will cover people with disabilities and socially vulnerable populations. To achieve the level of vaccinations in our population that would begin to slow the spread of the virus, we need to take a health equity approach. Certain groups in our micropolitan communities are being disproportionately affected by COVID-19. The burden of disease these groups carry can make them feel neglected by existing efforts from healthcare and government agencies during the pandemic. This is our opportunity to show these groups that we care about their health and well-being by directing our vaccine efforts towards addressing the barriers to vaccination they are experiencing. As vaccine providers, to promote health equity, your main task is to make COVID-19 vaccinations more accessible for the members of your community that are being disproportionately affected. In order to be successful in our efforts to make the vaccine more accessible, we have identified the major barriers to vaccination and have come up with strategies to overcome these barriers. Let's begin with what health equity means. Health equity means everyone has the opportunity to be as healthy as possible, regardless of one's social environment. Unfortunately, external factors can create obstacles that interfere with an individual's ability to be as healthy as possible and create health disparities. These external factors can include anything from socioeconomic status, discrimination, or proximity to health services. In the context of COVID-19, the opportunity to be as healthy as possible would be advanced by being vaccinated against the virus. Here we are seeing health disparities in both health outcomes from COVID-19 and vaccination rates among certain populations in our Iowan communities. As previously mentioned, certain populations in our micropolitan communities are being disproportionately affected by COVID-19. These populations have experienced higher rates of COVID-19 infections, more severe and more fatal cases, all while experiencing lower rates of vaccination. We also mentioned the impact external factors can have on our health. Some examples of the external factors contributing to these health disparities include immigration status, socioeconomic status, and minority status. These factors contribute to the lack of access to COVID-19 vaccines and reinforce adverse health outcomes. Within the state of Iowa, the populations experiencing disparities in vaccination coverage include racial and ethnic minorities, immigrants and refugees, people with disabilities, and socially vulnerable populations. Racial and ethnic minorities have been disproportionately affected by COVID-19, and for much of the pandemic, they have experienced lower vaccination rates. One such explanation for the increased impact of COVID-19 on these communities can be attributed to the greater representation of racial and ethnic minorities as essential workers. The nature of their work combined with the social vulnerability of being a minority reinforces these COVID-19 disparities. Social vulnerability refers to the social and structural factors associated with adverse health outcomes. These factors can include poverty, lack of access to transportation, lower levels of educational attainment, crowded housing, or by simply being a racial or ethnic minority. A socially vulnerable population has additional needs that need to be met as they tend to experience barriers that a non-socially vulnerable population would not experience. In the context of COVID-19, socially vulnerable populations experience barriers to receiving COVID-19 vaccinations that non-socially vulnerable populations do not experience. These barriers to vaccination might prevent the population from receiving a vaccine, which in turn increases their risk of infection from COVID-19 and puts them at greater risk of hospitalization and death from COVID-19. Another factor contributing to racial and ethnic COVID-19 disparities is historic and current experiences of discrimination and racism related to the government and U.S. healthcare system. This mistrust extends to vaccines, vaccine providers, and the institutions that make recommendations for vaccines, such as the FDA or CDC. Thus, some people might not trust pharmacists giving out COVID-19 vaccines, and so it's important to understand that historically, many of these populations have reason to not completely trust the healthcare system and government. More information on this mistrust can be found in Appendix C of the toolkit. Finally, deprivation of resources, structural racism, and systemic inequalities have contributed to the COVID-19 disparities we are seeing with racial and ethnic minorities. An example of deprivation of resources are things like less available testing, treatment, and vaccination for areas where high concentrations of racial and ethnic minorities live, work, and play. These disparities are best explained by the historic and current systemic inequalities and structural racism in the US. These underlying health inequities and social inequities are contributing to an increased risk of infection from COVID-19 and experiencing more severe illness and even death from COVID-19. An example would be one's employment. As we discussed, racial and ethnic minorities are disproportionately represented as essential workers, which puts them at higher risk of occupational exposure to COVID-19. Many of these essential workers are customer or person-facing, meaning that they have to interact with people who could potentially have COVID as part of their work, which is further complicated by factors such as them not having or only having minimally paid time off or benefits that would allow workers to miss days of work to get a vaccine, recover from potential side effects from a vaccine, or take time off if they have a positive COVID-19 test result, leading to further spread of COVID-19 in the field. The disparities mentioned in the previous slide are exacerbated by a lack of access to COVID-19 vaccines for racial and ethnic minorities. For some members of this population, this includes a lack of transportation to receive a vaccine, lack of childcare during vaccine administration, and/or inability to take time off work. Time off work can relate to inability to take the time to receive a vaccine during a shift or inability to take a sick day if the individual experiences side effects. Cultural differences and language barriers can also make accessing a vaccine difficult for this population. We will talk more about language barriers and how to address them later in this video. As a subgroup of racial and ethnic minorities, immigrants and refugees are also experiencing low rates of vaccination. Major barriers for this population include access to the vaccine and misinformation about the vaccine, such as what documentation is needed to get a vaccine and concerns about providing personal information. There has been confusion and misinformation from both vaccine providers and individuals as to what documentation is needed to receive a vaccine, and unfortunately, this information has prevented some interested individuals from being vaccinated. Vaccine providers should rewatch video 2 of the series for a recap on documentation. Now, to combat the misinformation, let's break down the common concerns immigrants and refugees have with the vaccine and identify communication strategies for vaccine providers to address the concerns of this population. Similar to video 2, this information on documentation is very important, and we need to make sure we are spreading accurate information. Vaccine providers need to be aware that no documentation is actually needed to receive a vaccine, and that you are responsible for ensuring your community members know that they do not need to provide any personal information in exchange for a vaccine. Some of the common concerns immigrants and refugees have with providing personal information include fears that certain information will be used by immigration authorities, or that utilizing the free vaccine will be marked on their record as a public charge and impact their future immigration status, or fearful that not having the requested information will draw attention to their immigrant or refugee status. Again, for these reasons, it is so important that vaccine providers facilitate open communication with their communities so they know they can receive a vaccine without needing to provide personal information. Vaccine providers may want to communicate that you have to ask for certain information, but that the members of the community are in no way obligated to provide the information asked for. Other barriers experienced by racial and ethnic minorities include language and literacy challenges. The effectiveness of clear communication between the vaccine provider and individual is dependent on the ability to meet the language needs of the individual. To facilitate clear communication, vaccination sites should have interpreters and translators available. Consider partnering with local community-based organizations as a resource for translation services. If it is not possible to have interpreters on site, vaccination sites can utilize phone-based interpretation services. Additionally, sites can use printed FAQ sheets in a variety of languages to address some of the common concerns. Language access needs to include the entire vaccination process, including registration, informational materials, websites, etc. Additional resources on ways to address language barriers can be found in the supplemental materials section of the toolkit and in video 3 of the series. Another common barrier is the potential cost of the vaccination process. While the vaccine itself is free, the potential costs include the cost of childcare and transportation cost for the vaccine appointment, wages lost for time off work, including time off to get the vaccine or time off for side effects, and healthcare costs if treatment is needed for side effects or adverse reactions. To overcome this barrier, consider setting up vaccination sites at frequented locations in the community, such as large job sites, churches, or community centers. Have these sites located near public transit stops or bring a mobile clinic to neighborhoods in your community. Another consideration is to extend vaccination site hours beyond core daytime hours to accommodate the needs of the workers in your community. Another barrier is limited access to register for vaccines. The best way to overcome this barrier is to simplify registration procedures by offering in-person registration and/or walk-in appointments. This is crucial for those that lack internet or access to technology that would be needed to sign up for a vaccine appointment. Although walk-in appointments can be challenging to coordinate and staff, they are vital in maintaining equitable access to vaccinations. Again, make sure registration is accessible for those with limited English proficiency or limited literacy. Ensure websites with vaccine information are accessible for screen readers. Resources for ensuring website accessibility can be found in video 3 of the series. Perhaps the most important consideration to promote health equity is to try to increase accessibility of the vaccine. Resources to overcome some of these barriers can help improve access to vaccination among members in your community. Connecting with existing programs in your community to help people overcome these barriers is important. Talk to local community-based organizations and leaders to find out what resources may exist in your community that your organization can partner with to help get more people vaccinated. Here are our references for this video. In the next video, we will discuss health equity considerations for people with disabilities in socially vulnerable populations.